Hello and welcome to the topic Arterial Blood Gas Interpretation. By the end of this session, you should be able to recognize the indications of an arterial blood gas analysis, recognize the normal values of the components of an arterial blood gas, able to interpret an arterial blood gas result in a structured manner, and finally, identify the causes from the arterial blood gas results. Let's get started. Interpreting an arterial blood gas is a crucial skill and is especially important in critically ill patients. Arterial blood gas analysis can be used to assess gas exchange and acid-base status as well as to provide immediate information about electrolytes. It is always useful to have access to any previous gases. This is particularly important if your patient is known to have chronic respiratory disease with existing chronic arterial blood gas changes. Let's look at the reference ranges. So the normal values of an arterial blood gas are as shown in this slide. The pH ranging from 7.35 to 7.45. The partial pressure of oxygen is between 80 to 100 millimeters mercury. Partial pressure of carbon dioxide will be ranging between 35 to 45 millimeters mercury. Bicarbonate levels between 22 to 26 millimoles per liter, and base excess can range from -2 to +2 millimoles per liter. Even though the normal ranges are provided in the blood gas results, it's always useful to have an idea on the normal ranges so that quick interpretations can be made. The 5-step approach to interpreting a blood gas begins with step 1, which is identifying is the pH acidic or alkalotic. If the arterial blood gas results reveal pH values that are not within normal ranges, the pH level is then either acidotic or alkalotic. The lower the number, the more acidic the pH is. Contrary to that, the higher the number, the more alkalotic the pH is. Even though you notice a normal pH range, you will still need to look at the partial pressure of carbon dioxide and bicarbonate levels in order to see if there's presence of compensation. Step 2 is determining whether is it a metabolic or respiratory component. After determining if the sample is acidic or alkaline, next is to work out if it is due to a metabolic or respiratory cause. If the cause is respiratory in nature, the partial pressure of carbon dioxide value will change in the opposite direction of the pH value. For example, if pH is low and the partial pressure of carbon dioxide is high, the patient has respiratory acidosis. If the cause is metabolic in nature, the pH and bicarbonate values change in the same direction. For example, if the pH and bicarbonate are high but partial pressure of carbon dioxide is normal, the patient is said to have metabolic alkalosis. The next step is to determine whether is there compensation or not. If the partial pressure of carbon dioxide or bicarbonate levels go in the opposite direction of the pH, then the patient has compensation. Compensation is the ability of one system to attempt to balance the pH when the other system is causing imbalance. For example, in respiratory acidosis, the bicarbonate levels will increase to bring the pH back to normal. The respiratory system can compensate within seconds, but it may take hours for the metabolic system to compensate and buffer. Next is step 4, which is calculating the anion gap if a metabolic acidosis case is present. So there is a formula to calculate the anion gap, and that's shown in this slide. A normal anion gap is approximately 12 milliequivalent per liter. If the anion gap is elevated, consider calculating the osmolality gap in compatible clinical situations. Next would be the 5th step, which is determining relationship between the anion gap and the bicarbonate levels. If an increased anion gap is present, assess the relationship between the increase in the anion gap and the decrease in the bicarbonate levels. This ratio should be between 1 to 2. if an uncomplicated anion gap metabolic acidosis is present. Before looking into the details of the analysis, it's important to look at the patient's current clinical status, as this provides essential context to the arterial blood gas results. Below are few examples to demonstrate how important context is when interpreting an arterial blood gas. A normal partial pressure of oxygen in a patient on high flow oxygen. Now, this is abnormal, as you would expect the patient to have a partial pressure of oxygen well above the normal range when this level of oxygen therapy is provided. A normal partial pressure of carbon dioxide in a hypoxic asthmatic patient. This is a sign that they are tiring and need ICU intervention immediately. A very low partial pressure of oxygen in a patient who looks completely well, is not short of breath, and has normal oxygen saturations may indicate likelihood of a venous sampling. Let's look at the two types of respiratory failure. We have type 1 respiratory failure, which involves hypoxemia, where the partial pressure of oxygen is less than 60 millimeters mercury, with normocapnia, where the partial pressure of carbon dioxide range between 35 to 45 millimeters mercury. Type 2 respiratory failure involves hypoxemia with hypercapnia, whereby the partial pressure of carbon dioxide would exceed 45 millimeters mercury. Now, this slide shows us a quick knowledge tip where there are 4 types of acid-base imbalance, beginning with respiratory acidosis, followed by respiratory alkalosis. Here we can see the pathophysiology for respiratory acidosis is the inadequacy of alveolar ventilation leading to carbon dioxide retention. Among the causes include respiratory depression, Guillain-Barré syndrome, asthma, COPD, and at times iatrogenic in nature. As for respiratory alkalosis, there is an excessive alveolar ventilation resulting in more carbon dioxide being exhaled, and this sort of condition is seen in anxiety attacks, pain, hypoxia, pulmonary embolism, and pneumothorax. Next, we want to look at the metabolic component, where it's divided again into metabolic acidosis and alkalosis. In acidosis, there's an increased acid production or decreased acid excretion, and this can be further divided into high anion gap acidosis and normal anion gap or low anion gap acidosis. As for metabolic alkalosis, there's decreased hydrogen concentration leading to increased bicarbonate levels, and this is seen in gastrointestinal losses, renal losses of hydrogen ions, and sometimes in iatrogenic situations, such as if there's an addition of excess alkali, such as seen in milk alkali syndrome, even though rare. So we have come to the end of this session. We hope it was insightful. Thank you.